So I am going to focus on something a little bit different. I'm going to drill down on an area of competence in the workforce, about supporting people from diverse ethnic communities in our work. So that's one very small ingredient of that big cake, potentially. And cakes is a flavour here, isn't it? So I could have the next slide, please. I'll do it myself, can't I? So on Wednesday evening, I think it was, you had a session that some of the authors of this particular paper were present at and expounded on and shared quite a lot of very powerful experiences. I haven't seen it all, I've just seen it through tweets, but I'm looking forward to watching it. But I don't know if all of you have seen this particular paper that came out in Palliative Medicine, and I don't know what you felt about it. It made me feel quite uncomfortable. And I don't like feeling uncomfortable, and I wouldn't think that I'm alone in that dislike of feeling uncomfortable. What do we do when we feel uncomfortable is quite an important thing in the theme of this talk, really. And it made me reflect on work that I'd done quite a long time ago about what happens to the workforce. At that time it was focusing on cancer services and the workforce supporting people from diverse ethnic communities. And what we found that if you feel uncomfortable, if you feel anxious in this context where you're worried that you might do something wrong, you're worried that you might offend people, you're worried that you might be racist, what do? Is you do less than you normally would, was what came out of that. So there's an element of paralysis that happens because you feel worried, anxious about those things, and you also don't like that feeling of not being competent to do it. And you reach for the things that you feel certain about. So sometimes that's the context of cultural competence that tells you, okay, Muslims do this, Hindus do that, a very sort of tick box kind of exercise potentially. And you certainly feel inhibited from doing the sort of things that actually make your practice excellent. And that's a bit paradoxical, isn't it? So we're in the most complex of environments and we do less than we normally would, rather than put our enormous skill sets into play. So that's our challenge, isn't it, to enhance the workforce. And then thinking about this paper, and maybe this is what some of what was shared on Wednesday evening, we've got to move from our processes focus and our doing the same sort of things to an outcomes focus, which may mean doing things entirely differently in order to achieve the same goals. So that was one challenge I picked up from this in thinking, why am I uncomfortable? Let me reframe this. Let me be liberated by this paper. And it took me even further to understand the difference between equality, equity, because I didn't really understand that before. And I knew the words, I kind of knew it in theory, but I didn't really get it, I don't think. And I think thinking about that paper particularly has helped me really get what equity really means in terms of actions that we might need to take as organisations, but in our own individual practice. And then also how liberating that could be. And you talked about being liberated by collaboration, that actually, if we think in different ways about outcomes, we can make it better for everyone. But it's different, but more equitable. And you've mentioned the ambitions in the earlier talk, and I want to focus in on how this element of competence in the workforce in supporting people from diverse ethnic communities particularly speaks to ambition 1 and ambition 5. So treating people as individuals and being prepared to care, our competence. So these are the statements that go with those ambitions. competent, compassionate, and confident care. Now, how do we achieve that with staff who are anxious that they might do something wrong, they might offend people, or they might even be accused of being racist, which is something that is a scary thought, isn't it? Because none of us want to be in that place where our desire to do good isn't so. So I've been working on a project funded by the National Institute for Health Research, and that has given the enormous privilege of talking to 40 patients and families who are living with advanced illness or have had people die from advanced illness about their experiences, particularly with a focus on what does this mean to them about thinking about the future, about deterioration and dying. How does our sort of policy model of filling in a form that has people's advanced care plan on it, but working back from that, offering a conversation, offering the opportunity to have a conversation, to make decisions, to fill in that form. But the policy is about filling in a form, isn't it? The ambition is about offering the conversation in a compassionate, confident, and competent way. So, as part of the outputs from this project, we have constructed some stories, and I'm going to play you a short version of one of those stories. And these will be available in part through e-learning for health on a new e-ELCA module, which will come soon, but also resources on our website to hopefully, the aim of which is to help enhance workforce competence in being confident, competent, as well as the compassion that they want to give to people. So this is a gentleman, Mr. Sampson. He's got prostate cancer, and he's come to see the doctor today because he's in some pain. Now, many of you will be familiar with the iceberg model of cultural awareness, cultural competence, which essentially is there are some things that are easy to see about people, but there's a whole lot more that is fundamental to who they are, what they believe about their prostate cancer, or they're working with the doctor, or what they're going to do about their pain management, their morphine. There's an awful lot of things that we need to understand or get some awareness of that we can't easily see in order to deliver that care. So the iceberg model of cultural competence helps us with that. Cakes, theme of the day, okay? So one of the things that's really important in addressing this issue of understanding difference, particularly difference in culture, is beginning to think about our own first. Okay, so do you have a culture? We all have a culture, but we don't really think about it often because it's just how we live, isn't it? Okay, so birthdays. How do you do birthdays? How do you do birthdays? Think about it. What do you like to do on your birthday? What is your tradition? My cake would be a chocolate cake with chocolate butter icing with Maltesers on the top. So it's not this one, but I would have a cake, and I have that cake because that's what I always used to have when I was, old enough to remember anything. So that goes back to my sort of childhood tradition, how I celebrate my birthday. Preferably someone make it for me, but now it has to be me that makes it, and I give it to other people now. So that's a bit about my culture, isn't it? It's my family culture. The fact that I have a cake is perhaps beyond a family culture to maybe English culture. And there are things about birthdays that we assume are a little bit universal, but aren't. So some people don't celebrate birthdays at all. Some people, the focus is on giving thanks to those that have given him the privilege of life. I've just put some examples here of how different it might be for people. And if I was given a workshop, I'd get you all to discuss it and share. And that really gets people engaged in what culture is. It's a happy celebration. It's not about what do we do about our funerals. Examining our own culture allows us, perhaps, in a safe way, about something that's nice, allows us to then begin to think differently. And it's thinking differently that is really key to this, isn't it? So I'm going to play you our story that we've developed from the themes that people have told us in this research that we hope might be useful for further development of compassionate, confident competence in health professionals. So see what you think about this story at a kind of level of what's in it, what does this gentleman, what's going through his head. Think about that cultural iceberg of things that you saw on the picture that I saw you and gave you. He's got prostate cancer and he's coming with pain. What are the things that you're learning from this first-person narrative of a story which represents the themes that come out from our research? So hopefully the sound will come on when I press again.
I'm going for some food as soon as this is over. I deserve it after all this fennel tea and tasteless veg my wife's been putting down in front of me. And I know the doctor's going to try and twist my arm. You need to think about what you want to happen over the next few months, Dave, so we can put the proper plans in place. My dad died of cancer. He made me promise that his funeral would be a thing of joy. The people here, son, they don't know how to die. And when they do, the way they are so quickly dispensed with and forgotten should be a warning of the way that they will treat us. So we have to stand up for our rights every single day. And he was right. As soon as the treatment stopped working, they just washed their hands of me. And now, of course, when things are properly on the downward slope, they have to appear to make an effort. But I know what's really going on. That's right, doctor. Now that the chemo's not working, you want me to sign on the dotted line so that I don't hang around too long. Well, I'm not signing anything. Maybe I should have asked my wife to come with me. She's obviously worried, but I've told her it's nothing important. And I don't want her there, getting upset and confusing everything. Getting talked into things like she does with her sister and all that diet mumbo-jumbo. It's simple. I just need to stand my ground. Tell him I know that things aren't good. That we all step off the boat at some point. But they're not going to get rid of me that easily. That I'm no fool.
So I wonder how powerful you found that in a way that if I'd put up some of the salient points about people might not trust us or people might have a family history. I wonder if you found that having a story told from a first person might be a way forward in discussions and really seeing how the nuances of the things that are sort of bullet points about that cultural iceberg actually play out in people's lives. And that therefore might help our very compassionate workforce begin to want to walk into that uncertainty environment that makes them feel very anxious in a different way, that they can feel more willing to work with uncertainty. So one of the concepts that came across in our research quite strongly is that everybody wants to feel known. Now, we all want to feel known. We don't want to be ignored, do we? And there were lots of examples of how the system ignores people, like, they never had my notes there. I had to keep telling my story over and over again. And that's a commonality across us all. But does it feel more impactful when you already feel very hidden in society, ignored in society. So the impacts might be greater of the things that happen for everybody. And that, going back to that paper, the impacts of not having visiting was greater for some people for some really important reasons that we have to consider. So being known is more than just, oh, hi, I remember your name. And in some cultures, and this is a Zulu word, sawubona. Is anybody here who speaks Zulu? Because please do help me if you understand this more than I do. But this is about acknowledgement. It's more than politeness. It's, I am not a person unless you greet me. That gives me dignity. That means you see me. That means we're in it together. We are working together. So this, I think that word is really helpful in what we're trying to aim to do with everybody. But the complexities, the uncertainty, the things that might be really important to the person in front of you may be less able for you to know about because you don't share the culture, so you can't second guess it, and most of it is below that iceberg. So how do you begin to understand, share, give that position where people feel known and safe and can trust you and have that rapport building? To recognize their family influences. So Mr. Sampson talks about his father who said, they're just going to ignore us. They don't, they're a death-denying society, not like us. We need to do it a different way. How do we get to understand that? The drivers behind people's behaviors and their engagement in the way that we want to get alongside and help. There may be religious things, or there might not. But we certainly can't assume that Muslims do this. Yeah, because there's generational things, there's individuality, there's different interpretations of fatwas. Some people will consult with their imam, who will say, yes, a DNA CPR decision is in line with the Quran. Let me show you the verses. Others may have a different take on that, say, no, absolutely, life is God-given and you have a duty to pursue it to all ends. So you'll come across a whole diversity of discussions around DNA CPR and advanced care planning. It isn't Muslims do this. So maybe Sorbona helps just get into what that means for our workforce. This is another way of looking at that model of the importance of knowing the patient. But there's nothing distinct. This is the same for everybody. Yeah? Our holistic, psychological, spiritual, social, physical care, that model works, but it's how we do it to get the same outcomes. And it may be we need to do things differently in that than we would usually do. And one of the things that we came across from some health professionals, I do the same for everybody. That's equality. I give that same sort of psychological, spiritual approach, but maybe that doesn't give the same outcomes if you do the same thing in the same way. Language is clearly a really important first step, isn't it? So, challenge to you, in the places that you work, if someone comes in and you can't speak the same language as them, how do you find out what language they're speaking? Do you have something like this in your unit that says, here's a piece of paper, pick out, tell me which language, and then I can get the interpreter? But, it's such a sort of fundamental step. But how do we do it? We should all be able to find out what language people need us to work with them in and bridge that And sometimes families and patients want that to be through family members. But we know that there is a range of evidence to say some things about that are good, some things about that are not good and not helpful. And we had quite a lot of families saying they expected me to do that, and that was just wrong, yeah? As well as from health professionals saying, I just wasn't confident that what I was meaning about resuscitation had actually been translated correctly, because they came back 3 weeks later and said, no, he doesn't want to have that form anymore. He didn't understand you. So fundamental steps. Be able to find out what language someone speaks and have access to interpreters of quality to do that. And our workforce should learn how to work effectively with interpreters, be that family members or be that professional interpreters. Is that a core skill? Do medical students learn it? Do nursing students learn it? If not, I am asking, why not? Why is this being able to speak with people, which we have to do differently with some people and with other people, why is that not, to achieve the same outcome, a core fundamental built into everything? So one model that I've found quite helpful is the cultural humility model. I didn't invent this, and I need to find out more about the provenance of it. But working across cultures, we've got things that tell us about competence, sensitivity, and humility. And I think it fits well with the sort of themes that have come from our patients. So listening comfortably, listening when you're thinking, I don't know what to do here. Yeah, I don't know if working with this interpreter is actually being successful enough. I really don't understand anything about Jainism, so how on earth do I support this family? Listening, being aware of our own culture and conscious and unconscious biases, and being comfortable with that. And taking that step of authentic curiosity. I'm interested in you. But being aware also that people might go, well, how can I'm not going to tell you that, because are you trustworthy? Yeah? I'm not going to share with you that on my journey from Uganda to here, X, Y, Z happened, which is why I'm really scared about the pain that's happening in my liver. Yeah? How do we get to that? We might never. But what's important to people, setting our stall out that we want to do what's good for you. And very simple things about people having phrases that might allow them to step into that arena of, I can't second guess, I don't feel very competent in this, so you need to teach me. What do I need to know about you that will help me give the best care possible? You need to teach me. And we don't feel very comfortable about that often. It takes a lot of confidence to work in uncertainty and feel confident about it, I think. Yeah? And we need to embrace this complexity. All sorts of stuff will come that we never knew about. How do we get someone back to Ghana to die? I don't know, but I've met some very brave doctors that are willing to go all miles out to achieve that wish for people. And what do you do with a syringe driver? Yeah? The cultural humility model has an acronym linked to it, which I think is quite helpful for many people to begin to work in this arena. Being humble, continuing to learn, emphasizing respect. But coming from that place of, I have a culture, let me share my culture, and I'd be interested in your culture. They're really important things. And I'm come to the end of my talk there, but hopefully we'll have a bit of discussion through questions. Just want to acknowledge the project, the funders, the many people that have contributed to it, as giving us data, but also the team on the left here, particularly Zobia Islam, who's led the project. I hope you're excited about the findings that are going to come, and also the resources that you might be able to have access to take this forward in your organisations and your practice. So thank you very much.